And like, you were probably surprised that the cardiologist you were talking to has never heard of the triglyceride-to-HDL ratio. And you're like, wow, how do I know it and you don't know it? That's weird. What primary care doctors need to understand, what mid-level providers definitely need to understand, and what patients need to understand is that the most preeminent cardiologist in your country, the majority of the time, they just follow the guidelines. They're not thinking this stuff through. They're not sitting at home at night studying and looking up studies and trying to go back to their physiology textbook. And does this make sense? That's number one. They're not doing that. They should be, but they're not. Probably the specialty I'm the most disappointed with is the endocrinology. When it comes to thyroid treatment, when it comes to sex hormone treatment, and when it comes to pancreatic function and even adrenal function, they're not digging down into the deep physiology, cell and molecular biology. They're just not doing that. They're just following what their association tells them to do, and they're not thinking this through. And that's very disappointing. So here's another thing that you would think the average cardiologist would know, since it's come so quickly to their lips to denigrate either a ketogenic diet or a carnivore diet. They should know the data behind those diets, right? They shouldn't be denigrating them if they don't know the data. And so the average cardiologist, probably the one you talk to, if you said, what percentage of people, if I put them on a meat-heavy ketogenic diet or a fatty meat carnivore diet, what percent, if I put 100 people on one of those diets, what percentage of them do you think their total cholesterol and their LDL cholesterol would go up, doctor? You know they're going to say, oh, God, 80, 90%, maybe 100%, right? So they don't even know the basic physiology of this, because the truth of the matter is, if you put somebody on a high-fat, meat-heavy ketogenic diet or a high-fat carnivore diet, if you put 100 people on there, about 33%, their cholesterol and LDL is going to go down. And about a third of people, their total cholesterol and LDL cholesterol is going to stay about the same. It's not really going to change. And about a third of people, their numbers will go up. And then about 1% of the people are lean mass hyperresponders. Their LDL and total cholesterol is going to skyrocket. So right off the bat, the average cardiologist has no idea that a third of people's cholesterol is going to go down if they start a high-fat keto or carnivore diet. They don't know that. And so how can they then be trusted to give a patient dietary recommendations when they don't even know the foundational physiology behind what's going to happen to a patient if they recommend a certain way of eating? That's one of the basic problems. And I think that if a doctor hasn't really studied nutrition, they shouldn't even give nutrition advice. And that goes for all specialties, especially if you haven't really looked into diet and nutrition, you shouldn't even make a recommendation. You should be honest. You should say, I have no idea what diet is best. I don't know what you should eat. Just, I don't know. Google it, watch some YouTube videos, because I truly don't know. I don't care about diet. I think if doctors were more honest like that and say, look, I'm board certified cardiology. I don't know anything about diet, and I'm not going to learn anything about diet. That's on you. You gotta figure that out.
Yeah,
that'd be a much more moral stance, don't you think? That'd be much more ethical to just admit to the patient, look, the only thing I know about diet is I watched the What the Health documentary, and I watched that plant-based documentary. But as far as reading all the nutrition research, I haven't done that, and I'm not going to. I haven't gotten my physiology and nutrition textbook, if you even had one. I haven't gotten those out and really looked at this. I have no idea about diet, and I don't care. You figure that out on your own, or I'll refer you to a dietitian. That'd be a much more defensible position for a cardiologist or an endocrinologist or a primary care doctor, to just say, I don't know and I don't care. I'll refer you to somebody if you want to look into that deeper. But doctors don't do that. They'll watch What the Health, or they'll watch, the Game Changer documentary, and they'll start to give dietary advice to their patients based on a documentary they saw. And that's ridiculous. I don't want doctors to watch the animal documentary and then start giving nutrition advice. That's not how you should do it. A doctor should know better than that. Now, the animal documentary might spur your interest, and you're like, I've never heard of that or thought about that. I'm going to look into that. right? That's what the documentary should do. It should not make doctors go, okay, I'm just going to start recommending carnivore. I'm not going to look into it.
Yeah.
No, I don't want that to happen. And you won't serve your patients if you do that. So please don't do that.
Speaking of the animal film documentary, in that film, I watched it 2 days ago. You said there's no signal suggesting that carnivore increases heart disease risk. Is there, like, one, are there studies that look at that? I know there's a keto trial, which is not carnivore, but it's keto, and carnivore, a good carnivore diet is keto. But also, what are other medical conditions that you have seen improved, reversed, or stopped for people being on carnivore?
So many. So let me first say this, because I'm sure you have a few medical students and residents and young doctors who watch this. LDL cholesterol is a proxy marker for heart disease. You have to understand that. ApoB is a proxy marker. If somebody's ApoB is elevated, that's not like, boom, guaranteed heart disease, guaranteed, elevated CAC score. The lean mass hyperresponder, one-year follow-up studies showed very clearly that you can have a sky-high ApoB or sky-high LDL. And if you are in the lean mass hyperresponder cohort, which is a very small percentage right now, your CAC score is not going to progress. You're not going to lay down more calcification just because your ApoB's high or your LDL's high. And they're going to come out with a 2-year follow-up, 3-year follow-up. There's more research coming. And so that's the first thing, is I want any healthcare provider to understand these things are proxy markers. They're not like, aha, I have discovered something. That's just a possible risk factor. Just like having an elevated uric acid level, that doesn't mean that patient has gout. There's 100 things that could cause the uric acid to be high. I've seen patients who had high uric acid for 20 years and never had a single gout attack. Any doctor who's been practicing for a long time, is like, no, that's right. I've seen that. Doctors got to stop being lazy. They've got to start understanding these things are proxy markers. They're not guarantees. You haven't uncovered something. You've just said, oh, this patient's at a little higher risk for this probably because of this proxy marker. We need to do further testing, or we need to have a conversation. That's the first thing. Now, when I first started recommending ketogenic diets and then later a carnivore diet for people, I considered them to be just temporary weight loss hacks because I didn't know a damn thing about nutrition. I had forgotten all the physiology, all the biochemistry, the cell and molecular, how the food interacts with the human body. Either I'd never been taught or I had forgotten it. Right. So I just thought, oh, you cut the carbs, you lose some weight, then you can go eat the American Diabetes Association diet, I guess. I don't know. But I kept having patients come back, and this is that signal that I talk about. I would have a patient who had lost 30 or 40 pounds with either meat-heavy keto or carnivore, but also their reflux symptoms had either gotten much better or went away, or their eczema cleared up, or their severe shoulder arthritis that they were considering having a reverse joint replacement for. It just stopped hurting. It wasn't hurting anymore. Initially, and every doctor, when you hear something like that, you're like, yeah, anecdotal, that probably doesn't mean anything. Or we all know, any good doctor knows that patients will blow smoke up your rear, right? They just like, oh, I love you, doctor. You just, and then we got the placebo effect to contend with, right? So there's all these things that muddy the water. That's true. But I kept hearing this signal, kept seeing this signal over and over and over and over. And then I had 2 or 3 patients with eosinophilic esophagitis, which has a black and white on the CBC with differential. Black and white, their eosinophils are elevated every single time I check this lab. And they have severe reflux symptoms, right? I had 3 of these guys who were all taking either Nexium or Prevacid or something. It went completely away. Not only did their symptoms go away, which is a subjective thing for a doctor. I'm like, well, maybe his symptoms went away, but I'm not in his body. I don't know. But then I would check his CBC with diff. His eosinophils are now normal. That's objective. That's black and white. He can't fake that. Right. Yeah. So I'm like, dude, how is this happening? How is this dietary intervention, which I'm telling people to do it just to lose 30, 40, 50 pounds? But also, when I checked their A1C, it used to be 8. Now it's 5. Reverse their type 2 diabetes with a temporary weight loss hack diet. What's going on here?